Probably I will add what has been told, that drug is very important. I will say drug is not so important in cardiac arrest. High quality CPR and defibrillation probably take a front seat and drugs comes in the last. Though most of the time we practice, the moment we come across with the cardiac arrest, before even assessing the patient, our comments are, epi de do, soda de do, calcium de do. Probably it's a very common thing which we practice. But I think it's a time to unlearn few things, that use of the drugs should be very judicious, rational, as well as we should have a very clear messages while we are ordering or instructing for drug administration. Because what happens, if you don't give the clear message, you say give adrenaline, everybody will have the different interpretation. What dose, what who, and who is going to administer. Probably at some instance, 5 people will administer adrenaline to a patient, and some instance probably nobody will administer the drug. So this is very important. Whenever CPR is in progress, once we have ensured that there is a high quality CPR is in progress, we have ensured that it is the shockable or non-shockable rhythm by applying the monitors. Now it is the time to look for what drugs to be administered. So as I said, it takes back seat. The front seat, the first thing is high quality CPR, ensuring all components as well as identifying the rhythm, and if it's a shockable, the shock, and then continue with the CPR for next 5 cycles and 2 minutes. And after second shock, this is the time first. So nearly it is around 4.5 minutes after the cardiac arrest, it is the time for administering the first drug. In cases of ventricular fibrillation or pulseless ventricular tachycardia, and if we talk about the asystole or PA, the time is almost after 2 minutes. Though it is said as early as possible you identify, until you attach the monitor, so you have to continue your CPR till that time, and then only you can think of administering that drug. So what are the different routes which you use in cases of cardiac arrest? The best route is the intravenous. Any peripheral line is more than sufficient to administer the drug. We should never try a heroic attempt that when there is a cardiac arrest and CPR is in progress, we should start placing a central line. Because we are going to waste time, we are going to compromise the quality and of chest compression, as well as we will stop chest compression while placing the line, so that will be detrimental for the patient. So any peripheral IV line is more than sufficient, no other line is required, so it's the most common and preferred one. The other routes, if IV access is not possible, the intraosseous access is another route which can be used and which can be accessed quickly if you are trained for it. And the third route, which is not a preferred one, but if you don't have an IV line, you are not expert and you are not able to get an intraosseous route, then endotracheal tube. But endotracheal tube is in place, so you can use that route for administration of the drug. So, but you should remember that here you should give a diluted form of drug, nearly 2 to 2.5 times of the doses of the conventional doses what you use, and should be diluted in 10 ml saline. Few drugs like epinephrine you can give, atropine, lidocaine, these drugs can be given with this. What is important for us to remember when we are administering the drug? All these drugs should be an IV bolus push, because there is a cardiac arrest. So for any drug to act, it has to reach to the heart. So 3 things we should remember: administer any drug as a bolus, push, flush with 20 cc of saline, and if it is the peripheral IV line, raise that arm for at least 10 seconds, so that your drug is reaching to the heart, and then only possibly you can get an effective action. So coming on the most important drug, epinephrine, the only drug in cardiac arrest, first and the only drug. We call it as adrenaline epinephrine. Basically it's an inotropic vasopressor. It stimulates the adrenergic receptor, increases a lot of pharmacological actions. Basically, increases the SVR and blood pressure. What is important for us as an ACLS provider, it increases the coronary and cerebral blood flow. And increasing this flow, it can make your chest compression more effective. Because the coronary perfusion pressure will go up, coronary flow will be higher, so your chances of return of the spontaneous circulation will be much higher. So, indication of epinephrine, in cases of cardiac arrest, all 4 cardiac arrest rhythm, ventricular fibrillation and ventricular tachycardia, we administer adrenaline after second shock. But in cases of asystole or PA, we administer adrenaline as soon as we diagnose, as early as possible. Besides this, here we administer this drug as a IV bolus push, followed by saline, 20 cc saline, and raising arm for 10 seconds, so that drug reaches to the heart. Besides this, it can be used in cases of symptomatic bradycardia, when the patient is having symptoms and signs, so we need to increase the heart rate. After administration of atropine, if patient is not responding, then we can start with the adrenaline infusion, and the dose should be 2 microgram per minute. That you have to calculate, because 1 ampule contains the 1000 microgram, so you have to calculate 2 microgram per minute. Or in cases of severe hypotension where patient is not responding to other vasopressors, this drug is maybe useful. And besides this, in anaphylaxis or severe allergic reaction where patient has collapsed, again this will be helpful. So 1 milligram IV, it can be repeated after 3 to 5 minutes. And after restoration of spontaneous circulation, if the patient is hemodynamically unstable, needs optimization, then possibly this can also be used along with the dopamine and norepinephrine as a continuous infusion of 0.05 to 0.2 microgram per kg per minute to improve the hemodynamics. Whenever you are using an endotracheal route for administration of this drug, use 2 to 2.5 milligram. It should be diluted into the 10 cc of saline. The second drug, which is used in cases of cardiac arrest, is the Amiodarone. It's a class 3 antiarrhythmic. Basically, it prolongs the cardiac action potential and refractive period of the atrial, nodal and ventricular tissues. So it decreases the chance of arrhythmias, and it also helps in increasing coronary blood flow, decreases cardiac oxygen requirement, and suppress the ectopic pacemakers, so that the normal pacemaker SNO can take over the activity. It is used to treat the tachyarrhythmias in the form of ventricular fibrillation, which is persistent or persistent ventricular tachycardia. In cases of cardiac arrest, ventricular fibrillation and pulseless ventricular tachycardia, the dose is 300 milligram, IV push again, and the subsequent doses should be 150 milligram. First dose is 300 milligram, and the subsequent doses will be 150 milligram. It can be repeated after 3 to 5 minutes. Right? In cases of other arrhythmia, that's a non-lethal arrhythmias like atrial fibrillation or other arrhythmias, we should administer this drug as 150 milligram over 10 minutes, and it can be repeated, and we can start an infusion of this drug with a maximum dose of 2.2 gram in 24 hours. So this is what the indication for using Amiodarone. So this is ventricular fibrillation, which is unresponsive to the shock, CPR and vasopressors, recurrent hemodynamically unstable ventricular tachycardia, and other arrhythmia like atrial fibrillation. Adverse effect, you should always be ready if you are using it in cases of atrial fibrillation or other arrhythmias. There can be bradycardia, any kinds of a block can precipitate. If given rapidly, it can lead to hypotension, and it can lead to a QT prolongation, which can be precursor for any kind of a ventricular arrhythmia. You should remember that if the patient is on warfarin, calcium channel blocker or beta blocker, the effect can be potentiated, and not in cardiac arrest, but otherwise it can lead to a lot of complications if used for the long-term administration. As an alternative to the Amiodarone, another drug, lignocaine, can be used for arrhythmias, for ventricular fibrillation or pulseless ventricular tachycardia. The dose is 1 to 1.5 milligram per kilogram of body weight, and after the loading dose, bolus dose, an infusion can be started 1 to 4 milligram per minute. Another drug which is important to discuss here, not in cardiac arrest, but in a lot of arrhythmias we use adenosine. It has an antiarrhythmic effect. It slows the impulse formation from the SA node, and what is important for us to remember that its onset of action is immediate and peak action happens within 10 seconds. So the moment this drug is administered, it will metabolize very quickly, so it has to reach to the heart very fast so that its action actually takes place, otherwise it will metabolize. So how do we administer actually this drug? This is very important. Whenever you are administering adenosine, it should be loaded on one syringe, another syringe of 20 cc of saline, both should be connected with a three-way, and push the adenosine, turn the three-way and push 20 cc of saline so that it does not metabolizes before reaching to the heart. First dose of adenosine, 6 milligram with the IV bolus, and subsequent doses, second dose, if patient has first dose is ineffective and patient is stable, then is tolerating, we can give the second dose as a 12 milligram. So basically, it can be a diagnostic use or therapeutic use. To differentiate between the arrhythmia, we administer adenosine, or therapeutic for rapid conversion of paroxysmal supraventricular tachycardia, including those which are associated with the accessory pathway. So you don't need to remember those technical things, but administration of adenosine and where it is indicated in cases of supraventricular tachycardia. Contraindication, you must remember that if a patient is hypersensitive to adenosine, or it can produce any kind of a block, though it may be very transient, but those patients who are having a bronchospastic lung disease or asthmatic patients, in those conditions probably you should be careful for administering this drug because it can precipitate the bronchospasm. Another important drug is the magnesium sulfate. Basically, it's a physiological calcium channel blocker, and it is used especially in the toxicity depointis polymorphic ventricular tachycardia. In cases of dialysis toxicity, or if you know that the patient is hypomagnesemia and having a ventricular arrhythmia, and in cases of preeclampsia or eclampsia for prevention of seizure. So indications, doses for VT and torsades, it is 1 to 2 gram in 10 milligram, 5% dextrose over a period of 5 to 20 minutes. And if there is a torsades with pulse, you can use it as an infusion as well. The side effects you should remember, there can be flushing, there can be hypotension, or there can be bradycardia. Another drug which we commonly use, sodium bicarbonate, routinely should not be used in all cases of cardiac arrest. There is strong indication if you have a documented metabolic acidosis, that's one indication, or there is a prolonged CPR of more than 15 minutes, then definitely yes, you can use. Or sometime when there is you know that this is a hyperkalemia, so as a part of anti-hyperkalemia regime, you can use the sodium bicarbonate. The dose, 1 milliequivalent per kilogram of body weight as IV push, and next subsequent should be given as an infusion, 0.5 milliequivalent per kilogram of body weight. Basically, if a patient is still not having adequate ventilation, in those conditions it can worsen the condition, because what will happen ultimately, sodium bicarbonate breaks into the into the bicarbonate as well as sodium. The bicarbonate attaches with the H ion, and ultimately it produces water and carbon dioxide, and if your ventilation is not adequate, then this will lead to a carbon dioxide retention, and ultimately acidosis will worsen rather than an actual improvement of the acidosis. So drug administration is very important. Some drugs can be given as a bolus, and some drugs to be given as an infusion, and some drug can be given as a both. So adrenaline, we can use both as a bolus and infusion depending upon the indication. Similarly, amiodarone, similarly atropine. But these two drugs, you should remember that dopamine and noradrenaline should never be given as a bolus, should always be given as infusion. And in cases of cardiac arrest, all the drug has to be go as a bolus, flush, and raising up for 10 seconds. If pulse is present, always use slow infusion except one drug, that is adenosine. In conscious patient, in cases of pulse present, even those situation, when you are administering adenosine, it has to be given as a rapid push. Thank you very much. If you have any questions.